these pieces. Past history, no longer smoking. Review of systems, noted above. So we have respiratory and cardiac up above. They also note no nausea, vomiting, diarrhea, fever, or other weight loss or gain. So we easily have between 2 to 9 systems on our review of systems. Exam, they got the constitutional, so they got 3 points of the vitals. They palpated the thyroid, they listened to the lungs and the heart. So that technically is only at a 213 because they only did 2 to 4 systems. The assessment and plan or complexity, stable hypertension, you're going to continue medications. Hypothyroidism, it's stable, continue meds. That's medication management, that's 2 stable chronic illnesses. That's a 214. Our history was a 214. So even though our exam is only at a 213, you only need 2 of the 3 on a return patient for it to qualify for the 214. You do not have to work very hard to get there. Another example with a cough. 75-year-old male with a productive cough for 5 days, worse at night. Patient also has a fever and chest pain. Patient is using cough syrup, no improvement. Past history or personal history, non-smoker. Review of systems, denies shortness of breath or heart palpitations. So we have 2, and we only need 2 of 9. Exam, they've got vitals, ENT, neck, chest, so cardiovascular, lungs, abdomen, and lymph. So they've got 7. So easily with history, we're in the 99214 category. We're in our HPI, we're in the 214 category. Assessment and plan, acute bronchitis, prescribe a Z-Pak, tell them to take elderberry syrup, follow up as needed. Now you did prescription drugs in this particular case. You have a couple of points for acute bronchitis, so it may or may not be a 213 or a 214 by medical decision making and complexity, but again, it doesn't matter because 2 of the 3 meet the criteria for a 99214. You have a complete history, you have an exam that falls into it, so you don't necessarily need the medical decision making for it to count as a 214. Someone asks a question, any comment on how reimbursement differs between a 213 and 214? We can't comment on specifics, but let's just say a 99214 pays more, and between write-offs and different things with insurance companies, I want to make sure I'm charting to be able to maximize my coding while being honest and ethical and not making things up. Again, this goes back to relevancy. If someone has a cough and you're doing, I don't know, what would be non-relevant? If you're checking reflexes and you're doing a full neurological exam and you're doing a full skin check and just doing pieces of physical exam to get to a 99215, that's when I'd say you're not being ethical and you're just doing history for the sake of doing history and physical so that you can upcode and get to the 215 by the guidelines. If you get caught doing that, they're going to ding you and downcode you back to a 213 or 214. But when it's relevant history, why miss it? Make sure you're getting paid for the work you're doing. So let's talk about new patients. I want to make sure we have plenty of time for questions. New patients are those patients you and no one else of your degree or specialty in your particular practice have seen in at least 3 years. So if you're a solo practitioner and someone disappears from your practice for 3 years to the day, it has to be